So, GI, gastrointestinal system. So, first off, my name is Kendall Wyatt. I am um, the instructional content strategist and the content director here at Picmonics. So, um, just a little bit about me. I started out as a paramedic, then I went to nursing school, and now I'm in my third year of medical school doing my rotations here in the Phoenix Valley. So we are broadcasting live from the Picmonic headquarters. We're actually inside of our audio sound booth where we record all of the Picmonics in our system that you learn. And uh, Basically a little bit about me. What do I do here at Picmonic? So I work with um, all all of our students, all of our users, and I kind of bring together all their comments and concerns, and I also work with our content. So I make sure that our content is medically accurate. I help make sure that it's relevant to you, and that what you guys are learning, if it's confusing, and I'm just kind of the liaison and the in-between to make sure that everything is working and to give you all those pointers and everything. And of course, to do these wonderful webinars on all of our system. We have lots of different webinars. If you've not seen any of them, we have webinars on all of the different systems, and we have them recorded on our YouTube channel as well as on our website, so you can go and review them after the fact as well. So let's go ahead and get started. What is Picmonic? If you haven't seen any of our webinars, and you've not heard anything about us, we take pictures, we take characters and turn them into all the medical facts that you need to know during nursing school, and basically put them all together so you can memorize everything. We're research proven to increase memory over 331%. So everything you need to learn. So let's say bipolar. We had a psychiatric webinar recently. We will show a bipolar bear. All the pharmacology drugs you need to know during nursing school. So warfarin, we'll show warfarin. We're going to show you a war fairy. And with warfarin, you need to remember PTI and R. You need to monitor that. And we're going to show you a PTI in our factory in this story that brings everything together. And don't forget, yes, we have like heparin. We have a hippie heron, which of course is a hippie type of bird that you'll see, and you'll see a PTT hourglass with that, so that you'll be able to contrast all the differences and keep everything straight in your mind. We have over 700 different topics for nursing, cover everything you possibly need to know. And what we're going to do today is go over the GI system and hit on some brief points. So what are we going to talk about? We're going to talk about the GI system as a whole, and with everything that we talk about, I'd like to just point out important points, and a lot of it is understanding the concepts of everything. Especially with GI, it's a big one to just really understand the big picture so that you can put it all together. And we're going to talk about kind of, I always just talk from a mouth to anus or mouth to rectum type of way to think about everything. If you think about from the mouth all the way down, there are different disorders all the way, and we're going to talk about some of them as we go, but the big things we're going to heavy hit on the contrasting things you need to know, the differences of knowing one versus the other, and what are those key points for you to know. That's what we're really going to focus on today. We're going to touch on some digestion right in the beginning, and then we're going to finish up with some pharmacology, just some quick drugs on things that you also need to know as well. So in case you have come to our other webinars, we got a fancy new light as well, so I feel like I've got a little bit of a pasty face today, so maybe I need to get some of that makeup, to put on here to get me some instant tan today, so I feel a little pale. I'm going to compare this to last week. So when we talk about learning body systems, and let me just mention one thing first. If anytime today you have any questions or you have a concern right away, you can go in our questions box in your control panel there, and you can type in your question and press enter, and we'll see all those. And if I see them, we can go right in and stop and address those if they're relevant. Otherwise, we do a QA at the end that we kind of go over all the questions and whatnot. So if you've seen any of our webinars, you've seen how we've built this body systems out on how everything you need to learn during nursing school. And I always, I teach this as this exact same mechanism every way, and I'm just going to quickly and briefly go over it, how you need to kind of think of the whole body and everything together. And if any of these problem areas, you should definitely check in with this and see our other webinars, because we have one for every single one of these systems. So first off, just the whole body. I always like to think of this whole human body as a fish tank. And this fish tank is kind of where everything that holds everything together. So the skin and the body itself holds all this stuff, and it holds, that's the whole body. It's the container. Just like a fish tank would be like the actual glass that keeps everything together. And inside of a great fish tank, you have pipes that kind of move everything around, and that's in the human body's veins and arteries. So we've got to move fluid around in the system. To be able to move things around in the system, like through the veins and arteries, we need a pump. Just like any great fish tank needs a good pump. And a good pump circulates, and that's exactly what the heart does. So if there's problem with the pipes, then the pump can compensate to increase and pump harder or faster to compensate. And then we have an entire webinar on heart failure and whatnot. Along with all of this, no fish tank and no body, of course, is complete without a good aeration system. So an aerator puts oxygen into the fluid, and that's exactly what the lungs do, which is exactly the same thing that an air pump would do in a fish tank as well. As always, you need a good fluid to have inside of your tank, and that's what the body needs blood for. And just like every single fish tank and body out there, as we build up all these waste products are the kidneys, and everything that kind of builds up. The kidneys clean it all out, and just like a filter does in a great fish tank. And if a filter isn't working, all this gunk builds up, and all these toxins build up in the human body, and that's exactly how you should be thinking about renal failure, is that toxins build up. Now, the GI system, which is what we're going to talk about today, is all about, creating, having sustenance and nutrition that our body can consume and then use as energy and fuel. And that's exactly what we need. We have here anything that's inside of a tank or a fish tank needs some energy or some fish food to keep everything together. So this fish food goes into the system, and we eat food usually through our mouths, right? We eat food, and we goes through our system, and we digest it and turn that into fuel. And if you think about a fish tank, that's exactly what you need to do. And just like everything else, we end up then making waste, which needs to be removed out of the system based on with some good filters. And the last one, which is another webinar we have, is just knowing that you need electricity, or you need something to fire all of this stuff to keep it all together, and that's exactly where we think about the nervous system, how these electrical impulses are all firing to keep everything together. So just as a good graphic example, you can see how all of these systems easily build on top of each other, and they actually work cohesively, just like they do in the human body, so that each system works together. And here you see the last one I just added is the GI system, inside of this entire other system with the pipes and the pump and the filters to keep you and give you energy and sustenance. And of course we have our battery for our nervous system as well inside of here. And this is exactly how you need to be thinking about the entire body of how this works. We're going to talk about the GI system and all of these problems and disorders, but if you don't have any energy and nutrition going in, or a certain portion of the nutritional tract is unable and not working the best, you can see where the body is not going to be able to get that energy in there as well. And we're going to go over those as well. So one of the things you really just need to understand is definitely absorption. We have a couple of different Picmonics on this. We have all of the different organs, but you really need to know kind of what is absorbed and where. And this is we have a really good Picmonic on this in its entirety, but let me just show you these two. We have here's a small intestine absorption and a GI absorption one, just to kind of show you these two quick examples. So we use these characters to keep everything in, and what you need to know, let's just look at the GI. Here's our GI absorption, actual Picmonic from just screen capped from our Picmonic learning system. So you can see that in the GI system, if you memorize where everything's absorbed, then you should be able to then know if you don't have that particular piece or that piece is not functioning, you should see where there's going to be a problem. And here's a really common one. Does anybody know the most common vitamin deficiency in the world? What the most common vitamin deficiency is? Kind of a trick question because I know what everybody usually thinks in nursing. So I see lots of different answers here, but the most common vitamin deficiency is actually folate. And folate, we know, works in generation of progenitor cells to create red blood cells and to create these cells, and works with DNA formation. We know that just like we always teach anybody who is a woman who might be expecting, we always have to tell them to take folate supplements, right? Well, that's along the same reason, because folate is the most common one. But here we can see inside of our Picmonic learning system that folate is actually absorbed in the jejunum. So if you followed along with this, we could see stomach. Well, alcohol is absorbed directly in the stomach. That's why if you drink alcohol, you can get drunk very fast. It absorbs straight into your stomach. It really doesn't, the stomach wall lining can absorb alcohol right away. The duodenum, we'll show it by a character like this dodo in denim, this dodo bird in denim, and you need to remember that that's really where iron is absorbed. And jejunum, of course, is folate. And the next one is the terminal ileum. And the terminal ileum is two important ones, and we're going to circle back to this as well, is vitamin B12 gets absorbed there. And here's an interesting thought over the whole, just a concept. So I don't really talk about diarrhea as as a GI thing. I don't really talk about it specifically today, but let's just think about if you had diarrhea. So if I increase the motility of everything running through the GI tract, or I shorten the GI tract, are we going to absorb as much of all of these nutrients? And the answer obviously is no. I mean, that's you. I always think that some of these things are rhetorical before I say them, but then somebody always gives me a weird answer. But if I give somebody diarrhea, I'm essentially evacuating everything out of the tract. Diarrhea is the body's mechanism to say, oh no, this is something bad in here and I don't want it. Let's get rid of it. And as everyone who is human has had diarrhea, you know that is exactly what happens. And you need to put that in your mind as a concept as well. So we're reducing the ability to absorb all these things. So any type of diet or anything that causes or a disorder that causes a particular type of increased motility also decreases absorption of all of these things. So if you know exactly where, does anybody know which, if I said the terminal ileum, immediately which disorder do you immediately think of for the terminal ileum if I had to pick one? If I had to pick one, I said terminal ileum, vitamin B12 is absorbed there. That's great. I've got that here. Bile absorption, reabsorption is there. Resorption, rather, is there. And that's true. But what disorder? Does anybody know? You can just type it there in the question box. Oh, that's right, Tanya. Tanya actually said it's Crohn's disease, and that's right. We're going to talk about that in a second. So terminal ileum, specifically one of the places that's affected with Crohn's disease is the terminal ileum. It's kind of its favorite spot. So we see these people with lots of deficiencies, but specifically right away vitamin B12, as well as a decreased reabsorption of bile, because that's kind of where the problem area is. And just another side note, just so I don't forget this, because this is a really, really high yield point that I didn't put into this webinar today, but I wanted to make sure that I mention it. So if I have a patient who has pernicious anemia, does anybody put pernicious anemia? So if I said pernicious anemia, what does that really mean? What does pernicious anemia mean? I feel like I'm tongue-tied today. Pernicious anemia. Anybody? What? Okay, Alma, and looks like you say B12 deficiency. So what happens is the body can't absorb B12. And one of the big things that's a really high yield point here with pernicious anemia is I need to give you, what should you immediately know? If I have somebody who has B12 deficient and they have pernicious anemia, what does that really, how do I give them B12? I kind of already loaded the question here, loaded the proper answer, but this is really important. I see this missed all the time. I have to, that's right, you guys immediately, several of you jumped right in. Can I just give you B12 by mouth? No. If you have pernicious anemia, it's because you can't absorb B12. What you have to give it intramuscularly as an injection. And that's a really high yield point that you should know, because I see a lot of students get tricked up by that one right away, and that's definitely something you don't want to mess up on. For sure, that's a really high yield point. So we're going to talk about just some other random kind of fundamentals things that you guys should know, but I just want to, because I'm going to mention these all again. So here are some other really important points that you just have to know and understand. So dysphagia. Dysphagia is something, difficulty swallowing. Any patient who has difficulty swallowing, do we just go ahead and feed them? Do we watch them ourselves? The answer is no. They have to be evaluated by a speech therapist. And a lot of students trick this up because they think speech, they think that that's somebody who's going to teach somebody how to talk. But a big part, a majority of the part of a speech therapist's job, especially in a hospital or nursing home or medical point, is actually evaluating swallowing. So it's just the muscles of speech and the neck muscles as well, and they do an entire study to see how people swallow, and then like what type of diet that the speech therapist would recommend. So somebody with immediately, if you think somebody with dysphagia, what type of diet do you think that they're immediately going to be on at a minimum? What type of diet? So this is this is a really kind of a paradoxical thing that I see students also mess up on a lot. I see lots and lots of different, all over the place we hear. And the big answer is, what actually do people choke on the most? Yes, they choke on, a dry cheeseburger, right? I mean, that's possible. I actually choked on one once myself, thought I was going to die, but that's a whole separate corny story for later. But the point is, actually, you don't want to give them regular liquids. The answer is that they need to have thickened liquids, because thickened liquids are easier to move with your palate, and then you can swallow them easier versus just plain liquids, or water or whatnot, that is where you're going to that's actually more likely a choke risk in any of those types of patients. So don't mess that up. Somebody who's choking, or somebody has trouble swallowing would have an easier time swallowing something that's thickened liquids at a minimum, and then soft mechanical puree and those as well as they move up. But thickened liquids at a minimum, you'd never give them a liquid diet unless they had a clearing from a speech therapist or whatever. So just along the same lines, and just some important kind of points I want to put on. So dice. Dysphagia, we always show in Picmonic of a dice fajita. We just throw in one of our characters in here. And you're going to see all the characters that we use common throughout our Picmonic learning system. But inside here as well, I've just got some different types of diets. And there are some more, of course, but I threw these in here because I just want to hit some points. Regular diet, truthfully, even I can tell you as, working and doing my rotations right now, I just finished internal medicine not too long ago. There's not a lot of patients truly get a regular diet, especially if there's something wrong with them. So let's just talk about some of these. High fiber versus low fiber. We're going to talk on this one again, but high fiber diet. As soon as I say high fiber diet, you need to be thinking about what should immediately pop to your head. As soon as I say I need to give this person a high fiber diet, what is the purpose of giving someone a high fiber diet? What does fiber do? Let's just think about that. So lots of you guys typing in for constipation, so that's a acceptable answer. Fiber essentially creates bulk in the stool. So if I have somebody who has, if I need to create let's just call it like a fluffy bulk, right? Not a hard mass, because what we know about with stool, and we're going to talk about that too in a second, is it gets harder, more firm as it goes through. But if I put a lot of fluff and a lot of fiber in there, it's not really a digestible material, but in essence it holds water and it causes more bulk to form in the stool, which makes it easier to go to the bathroom and easier to actually stool and pass stool. A low fiber diet, of course, would then cause your stool to become more firm. And this is going to come right back and should circle right back in your mind so that it ties together. Cardiac diet is almost always a low sodium type diet. Low sodium, why low sodium? Because of hypertension. If we give you a lot of high salt and you consume lots of salt, most definitely it's going to probably cause you to have a higher blood pressure. So a low sodium diet for sure. And there's a whole, obviously, stages of sodium diets, and you should, refresh yourself with those. Renal diet usually just pretty much involves no protein, because protein breaks down into what? Protein breaks down into urea, and if you don't have kidneys working very great, do you really want a bunch of urea that you need to excrete through your kidneys? No. So we would give them that's more of a low protein type diet. And yes, there's low purine and whatnot as well. Diabetic, kind of along the same lines. And then, of course, low cholesterol. Just for somebody who has high cholesterol, we put them on a low fat or low cholesterol type diet as well. So let me just see what we got here. We got a couple of... Yeah, so a couple of students said that high fiber or fiber itself stimulates bowel movement, and just an interesting point. What actually stimulates bowel movement? Well, bowel movement actually. So if this is my bowel, I hope my bowel isn't this big or yours. But if a portion of my bowel is full of stool and it stretches out, that's what actually causes a reaction of peristaltic movements. So if it gets firm, it stretches out. That's actually what triggers that peristalsis movements of it moving and squeezing it down through the stool as well. So types of diets, not really something that I want to go over right now, but it's definitely something if you're not understanding of the types of diets, you should. Clear liquids obviously are clear. And when we say clear, why do we indicate clear liquids? Well, I see this all the time. Somebody's on a clear liquid diet versus a liquid diet. They're on clear liquid diets probably because of what reason? What reason would we put somebody on clear liquid diet versus just liquid diet? Does anybody have an example of why we would want somebody on clear liquids versus just liquid? Well, there's a couple different answers here. Surgery, lots of you guys are answering yes, but the big reason clear liquid diet is most likely to indicate whether a patient is bleeding or not. If they're on a clear liquid diet and something comes out colored, then we know that something discolored that stool. So we put somebody on a liquid diet. Do we want to give them a bunch of red Jello and a bunch of red colored things? No, because it's going to cause coloring and discoloration. And I see that all the time. Not really a high yield point, but definitely an important point as you get out in practice, for sure. Puree, mechanical soft, and the other types as well. Not so much important for us today, and some important points that I want to go over, but definitely something you should review. We have a Picmonic on it to help you review if you need to go over the types of diets. Something that I want to just mention that's a really high yield point. I see a lot of questions on this, and I'm not sure why, to be honest. But NG tubes. So does everybody know how to measure an NG tube? It's if you're not in your fundamental level, or you took that last year before, you need to remember this. It's really important. And this is really just understanding some basic concepts. I know there's more that goes with NG tubes. I'm aware of that, but I'm trying to pack in the highest yield points here. And the big thing is really just a quick and easy way to measure. How do I measure an NG tube? Well, I take my patient and I go from my nose. I take my NG tube and I go from my nose. I go to my ear, right? From nose to my ear and down to my xiphoid process. Where's my xiphoid process? Hopefully you know that, and that's the base of my sternum in the center. And that's going to give me that distance, approximate distance, all the way down into my stomach. So why do we use an NG tube? Well, they're nasogastric tubes. We can use them for lots of different reasons, and there's several different types. We could use it just to decrease the acid out of the stomach. We could use it to feed. We could put food through it. We could attach it to suction to decompress the stomach. We could use it as lavage. We can input something. If someone overdosed, we could insert like activated charcoal, and then it would bind, and we could suck it back out. Lots of different ways for NG tubes to be used. And the big point is knowing how to put it in and to know that you swallow it. So you curl around your finger, just kind of a trick for you to know. You curl the end around your finger, and then you put it into their nose. Nasogastric tube, naso to the gastric, nasal to the stomach. And you insert it in their stomach, or into their nose, rather. Insert their nose while they're swallowing some water to actually make sure that they swallow it and it doesn't go in the lungs. Definitely a good point. And we know that we need to aspirate contents, and they should be what? What do we expect those contents to be? This is hopefully pretty easy, and the answer is very acidic, right? We can aspirate those contents and check that they're acidic, or we can also do a chest X-ray to make sure that it's actually placed in the right place. I have a sensitive tooth today. I think I have a new cavity. Must be from all the candy that I've been eating. So the next thing I want to talk through, we're going to talk through some disorders. Oh, hold on. There we are. I clicked. I get a happy clicking. I apologize. So we're going to talk through some disorders, each one kind of just high yield points and what you really need to know. Something that is so important that I see students really struggle with is that they don't really understand, they don't really pay attention to what's different with each disorder. And GI is definitely one of those places where a lot of students have a lot of trouble because there's just so many different problems. And they say, oh, well, what do I really need to know to make sure that I can identify what's going on? Now, we're just going to run through them and we're going to talk about them. One of the first ones, and probably the most common one you're going to see with anybody that's over 30, 35, 40 years old, is gastroesophageal reflux disease, or GERD, right? I mean, that's a lot of words, and GERD is a lot easier. Now, I've got some signs and symptoms on here, but is this the only list? Absolutely not. I just wanted to highlight in here. We have a whole Picmonic on gastroesophageal GERD assessment and interventions. But let's talk about some that really clue us into that it's GERD. And this is how I want you to really think through what's going on here. GERD, gastroesophageal reflux disease. So just by the name, you know that it's a reflux. So what happens is the esophageal sphincter at the end of the esophagus, the lower esophageal sphincter relaxes a little bit or doesn't contract as well, and acid actually comes up from the stomach and regurgitates up into the esophagus. And when it gets into the esophagus, there's no feeling. Until it gets into that esophagus, and the esophagus gets irritated. And when it gets irritated, you have things like heartburn. And essentially is a burning type pain, right? But specifically, when would the acid more easily come out of the stomach? Is it when you're standing upright, or is it when you're suspended from your feet? I mean, just think about the logical concept there. Logical concept. Well, if I was hanging by my feet from a tree, which is not what humans are designed to do unless you're impersonating a bat, or a vampire, I guess, there's that possibility, you wouldn't have acid naturally going that way with gravity. But what happens is we sleep. And that's why the very first indication of gastroesophageal reflux disease is when a nighttime coughing or heartburn when they lay down, right? That makes sense. You've put that together. So if I don't have the interventions for gastroesophageal reflux disease in here because I want you to just think about what is the easiest thing you could do for somebody who says, I have heartburn when I sleep. What can I do to fix it? What is the answer? What do you tell them? What's the easiest thing you could tell them as a nurse? Ah, lots of you guys. Right away, got my easy one. I gotta not put ice in my drink. Teeth hurt. So you guys, everyone, looks like lots of you guys typed in the right answer, and that means you're really thinking. And maybe I preempted, maybe I made it too easy for you. I can make it harder. But the answer here is that you need to prop those patients up. You need to elevate the head of the bed when they sleep. Now, what I can tell you about esophageal reflux disease or any type of disorder that constantly irritates over time. What happens if I constantly irritate any tissue in my body over time for years and years and years and years? It becomes cancer. Anything. If I sunburn my skin over and over and over and over and over and over again because I love tanning beds, I'm going to get skin cancer, or I'm increasing my risk exponentially. So if I lay flat and I have this relaxed lower esophageal sphincter and I don't ever raise my head of bed, raise the head of my bed, then I am going to increase my risk of esophageal cancer exponentially. And that's how you need to think about this. Easiest things first. So we're going to elevate the head of the bed. What happens if I can't prop myself up on some pillows? I can't do that. Then what's the next option? The next option was just put the front of their bed under some blocks so that their entire bed is essentially elevated just a little bit. Julie says I need a root canal. I've had 8 root canals and about 14 of those caps. Caps? Yeah. I have awful teeth, so I'm always used to. Root canals are my best good friend because they get rid of all this awful tooth pain. Anyway. So easy things first is what we want to go with. So GERD, right? Easy, so easy with gastroesophageal reflux disease. We saw what the classic signs and symptoms are, and we know immediately what we have to do. Well, raise the head of the bed. Now, if I had an answer on there of giving someone something to reduce acid, if that's the only answer, that's not the best answer per se. We always want to think of the easiest and the cheapest first. Then we move on to medications or whatnot, and those types of things as well. So the next thing, actually, let me, yeah. Oh, so just as a side note here, so I talked about cancer, esophageal cancer. So any of these types of cancer, GERD is definitely something that's chronic, could be a risk factor for cancer. What are some other risk factors for esophageal cancer? And this is the entire GI tract that will increase your risk of getting cancer. This is one of those select all that apply questions that just everyone hates and ends up, yeah, GERD. Well, I mean, if you had GERD, that is a risk factor for cancer, especially if it's untreated. But what else? There's some really big ones here. Looks like Julie is volunteering to give me some root canals, I think. She says she's a dental assistant, so that's good. So what we're going with, what are the other things that are definitely increase the risk factor for esophageal cancer? And looks like several of you guys typed in several of the right answers, and that's right. The answers that I'm going for here are smoking, as definitely smoking and alcohol, right? So alcohol consumption irritates the GI lining. Smoking irritates those linings. And what happens is sometimes with medications, I like to explain, so we give oxycodone with acetaminophen, right? Why is oxycodone combined with acetaminophen when we take those types of pills? Because they have a synergistic effect because they work better together, right? That's why we have Percocet, which is oxycodone plus acetaminophen. They have a synergistic effect and they work better together. Well, in the exact same regard, if you have gastroesophageal reflux disease and you smoke and you drink alcohol on a regular basis, you have the trifecta of the synergistic effect of giving yourself esophageal cancer as well as other cancers. So you are synergistically combining those effects to give you a worse, definitely a worse or more probability that you're going to end up with esophageal cancer. So definitely not things that you need to, you just need to think of those. Smoking doesn't mean you're going to get esophageal cancer. No, but that combined with alcohol, combined with GERD, causes this synergistic effect together. So as we're breaking down the GI lining, one of the things that pops up and is so high yield is knowing peptic ulcer disease. So peptic ulcer disease is a fun one in the fact that, and I just really talked about the risk factors for peptic ulcer disease, and smoking and alcohol are definitely some big ones. What's another big one that's going to cause ulcers? What's another big cause of ulcers? There are two that I'm really going for here that I really want to, lots of, the answer is nursing school, right? Of course, yes, nursing school, med school, myself, stress, right? I mean, stress causes ulcers. I mean, the first, even several of you got caps, lots of stress right in here. And that's right. But the other one, I mean, that's definitely a cause, stress. But before stress, you need to think about this and never forget is NSAIDs. Non-steroidal anti-inflammatory drugs is a huge cause for ulcers. Definitely instant cause for ulcers. Another one good, Julie pointed out, was H. pylori. Helicobacter pylori is a gram-negative infection that can cause ulcers. How do we diagnose H. pylori? What is a way we could diagnose H. pylori? This is just a side note. Definitely something you need to know. Right. Oh, right away. I wasn't expecting such an immediate answer, and that is you can do an H. pylori breath test. So we're actually checking. You breathe in this device, and it checks your breath for the presence of the byproducts of H. pylori, because H. pylori creates byproducts that we can measure in your breath, and that's for sure. Lots of you guys typed in that answer for sure. I'm not sure sometimes whether you guys typed the answer in after I said the answer, or you've typed it in and you've not pushed enter, and then I say it and everybody pushes enter, because it's like 6 people always pop up right away. And I've done tons of these webinars now, and it seems like it's always it's one brave person who pushes enter. I don't know if it's and then everybody does or what. Who knows? So that's some interesting things with peptic ulcer disease. Now, the important thing to know with the peptic ulcer disease here is knowing where the ulcers are. This is something that's really important. So, let me just back up. So we have different types of ulcers. We have a duodenal or duodenal ulcer, and we have gastric ulcers. What is the difference? Now, we know a gastric ulcer is in the stomach, and a duodenal or a duodenal ulcer is in the duodenum or duodenum, however you want to pronounce it. It's one of those I just gave up on how it's really typed in. What is the difference between those two types of ulcers? And this is really important, really high yield points that you need to know to really kind of know how to treat as well. Signs and symptoms, that's right. So let's look at these signs and symptoms. So I broke them out here for you. We have Picmonic to help you characterize all of these, to characterize these, keep them straight. And here is what you need to memorize. And we have Picmonic for this. A duodenal or duodenal ulcer, you feed. You feed a duodenal ulcer, duodenal ulcer, and you starve a gastric ulcer. Well, what does that really mean? If I just memorize this, what does that really mean? What's the concept here? Well, this all ties in together. So let's just look at a gastric ulcer, since it's higher up, it's in the stomach. So the gastric ulcer, if I have a gastric ulcer and I eat, it's painful, right? It's painful. If I eat right now, let's say I'm going to, I got some pizza, I'm going to eat some pizza. I'm lactose intolerant, by the way. And I eat this pizza, delicious pizza, lots of cheese, extra cheese. And I eat it. My stomach secretes acid immediately, and I have pain. I have lots of pain. So what are some signs and symptoms I see with gastric ulcers? Well, I see people who don't want to eat because eating is unpleasant, right? Sometimes I tell people, you should try to get a gastric ulcer for weight loss, because gastric ulcers hurt when you eat. I just ate, and now it's hurting so bad. That is a gastric ulcer. We see weight loss with these types of patients because they don't want to eat. Those are all signs and symptoms. So we starve a gastric ulcer. The acid is produced and it causes irritation because it's an ulcer in the gastric lining and it's very painful. But a duodenal ulcer is different. What happens with a duodenal ulcer is it's painful all the time, but it feels better when you eat. Why? Because the acid is neutralized from the stomach, comes out, is decreased, and then it soothes this chyme, soothes the duodenal ulcer, duodenal ulcer. it soothes it, and then essentially, so these people have weight gain with a duodenal ulcer, and they feel better after eating. So they have pain right now. Oh, I got this pain in my chest and it hurts. Let me just go eat a couple of candy bars, and now it's feeling all better. And but then I gained 500 pounds, right? So that's how you can keep them definitely straight. It's definitely something. Um, Definitely saying the way you need to think about it. It's a concept. Then you can tie everything in. Memorizing all of the signs and symptoms is very important, but this is a way to think through the concept of how it's actually working. And this is what the whole goal here is. I want to preempt you on memorizing everything. It's great. Picmonic is amazing for memorizing, but I want you to really understand the concept of how these things go together. Why do we starve a gastric ulcer? Well, we starve a gastric ulcer as treatment because we don't tell these people never to eat again, but we then, if a gastric ulcer, it means it's painful when they eat. So that's because all that acid is produced in the stomach and immediately irritating to that ulcer, which is an open sore. So just an interesting thing. How do we diagnose a gastric ulcer? Is we would do an EGD, esophagogastroduodenoscopy. So we would do an EGD, and we would go down with a scope and look and see, actually visualize the gastric lining as well as the duodenal lining and see if where those ulcers are and if they're present for sure. So another one, and I'm sad I didn't keep these text until last, is moving on down the GI tract. Probably the most high yield one that you really just need to understand the difference of Crohn's disease and ulcerative colitis. These are such high yield points that you just have to know as a nurse. You've got to know this for your NCLEX or for your nursing exams. You just have to know the answer. But interestingly enough, we have Picmonics with all of the details for these, but there's really just some high yield points that you really have to know to keep them straight. And those high yield points are really to know that with Crohn's disease, what do we see versus ulcerative colitis? So I got them kind of spit out for you here already, so I'm sad that I can't really quiz you to see how you're doing or if you're paying attention, right? But Crohn's disease, what's characteristic of Crohn's disease? What's characteristic of ulcerative colitis? The big things here is Crohn's disease. We show you this crown of intestines for Crohn's disease. We got some really comical Picmonics for it. But the interesting thing about Crohn's disease is it's usually a non-bloody stool. It's because it's not necessarily an inflammatory process, so it's not really bloody stools with Crohn's disease. They often have 5 to 6 stools per day. Diarrhea, they complain of diarrhea like crazy. But how many? 5 to 6 per day. You know, that's a lot. I mean, we'll get to this TMI information in a bit, but you know, I feel like I would love to go to the bathroom 5 to 6 times per day, but it's definitely not a blessing for those people with Crohn's disease for sure. And the major affecting part is, of course, the terminal ileum. So the terminal ileum, and these patients always end up with anemia. So we have the stools. It's going to be diarrhea. It's going to be steatorrhea, you know, diarrhea, but not bloody stools, and 5 to 6 per day or so. But what's the difference with ulcerative colitis? So ulcerative colitis, it in fact affects the entire small bowel, but also the rectum. But what's different here is it's an inflammatory process. So it's an inflammatory process in the fact that you have inflammation of that gastric lining. So when you get inflammation of that, and then you're just constantly having these 10 to 20 stools per day, you stool a lot. I mean, I couldn't even imagine going to the bathroom 10 to 20 times per day. But if you had to, this is ulcerative colitis. And they have exacerbations of this, right? And we know that exacerbations of both of these often are exacerbated by food, which we're going to talk about in a second. But bloody stool, because of that inflammation of that lining, and then when you irritate the lining, just like you rub your skin and it gets raw like a blister, it ends up bleeding if you just keep rubbing it and rubbing it. That's exactly what happens. Stool, stool, stool. Eventually, you get bloody stool. 10 to 20 per day. And the big thing here is it's an inflammatory process, so it causes this more of a more stool. And something that I like that's we have a character I kind of wished I had thrown in here. It's called a tennis moose, and definitely we had a question of the day on it. It's a tenesmus. Tenesmus. Tenesmus is a medical term you need to know. Tenesmus, and it is the sudden urge to defecate, as in I got to go and I got to go right now. Tenesmus. And if you had ulcerative colitis and you had to go to the bathroom 20 times per day, that's tenesmus. You got to go right now. And that's really just the differences here. So here we have our anemia, anemone, We have our bloody toilet over here. Picmonic, we actually have entire Picmonics to help you memorize it. This one's bloody with a bloody toilet, and this one's just diarrhea with a regular toilet to help you keep track of which one's which is what we're actually great at, to help you memorize all these little details and keep everything straight. Something I want to mention, but I'm not going to go into big detail on, is diverticulitis and diverticulosis. Diverticulosis. So here's an interesting point on diverticulitis. When I say itis, right, I would just mention ulcerative colitis. Itis. What is itis? Itis is an inflammation. There is one thing that definitely. I had a student reach out to me not too long ago, and they said they were doing a bridge course where they already had their bachelor's degree, but they were doing like a high-paced nursing degree on top of it, one of those accelerated tracks. I'm sure several of you guys are doing that. But definitely something that I recommended was understanding medical terminology. Like, this is going to help you so much. And itis, I mean, this one's a simple one. Yeah, I know, itis. Inflammation, right? So diverticulitis is inflammation of the diverticulum. What are diverticulum? Well, they're these little pouchings right here. Diverticulum, that's the diverticulum. Diverticulosis, osis means like an outpouching or an enlargement of, and that's diverticulosis, so it's a giant outpouching. So itis is an inflammation, so an irritation of that lining, and osis is an outpouching. So if I were just to talk about them, diverticulitis is an inflammation, and diverticulosis is an outpouching. Diverticulitis happens because of inflammation of the entire tract, usually because of diet or an entire systemic process. Diverticulosis can be episodic, but a lot of because of diet. So something regarding consuming different types of food that would get stuck in these little outpouchings and then become infected or painful. And what is the one type of food, or a couple types of food, if you have a couple of examples, that I would definitely do not recommend to somebody who has diverticulitis or diverticulosis, somebody who has an ileostomy, somebody who has something I don't want you to have? Lots of you. Right away. Good answers. Immediately pouring in. The number one answer that I see most commonly on most exams is popcorn. I love popcorn. I love to go to the movies. I think, I usually go by myself and sit and cry for the first 15 minutes. But after I get over that fact and, the movie starts, I enjoy popcorn. And one thing about popcorn is it is awful for diverticulitis, diverticulosis, because those little tiny pieces, they don't digest. That's not fiber. That's just pieces that do not digest, right? And those end up causing irritation. They get stuck in those outpouchings. They irritate the gastric lining, and they cause extreme inflammation. Definitely a big one. And lots of you guys said nuts and seeds, and that's another really common one, is seeds and nuts. You gotta be really careful with those. But popcorn is the big one. Definitely one I see the most often mentioned in questions. But definitely seeds and nuts for sure. But most definitely popcorn for sure. Let's just keep moving on here. So we got a little diver lumpy here in our diverticulus diver on fire. And you see these little outpouchings on our diverticulosis, diver lumpy character. These are little outpouchings. Just to show you that's what an osis or a diverticulosis is, and that's exactly what it becomes in the bowel as well. Just these little extras. So the thing I want to talk about next, this is everyone's favorite, IBS, irritable bowel syndrome. And this one's an interesting one. I have irritable bowel syndrome, and I could talk about irritable bowel syndrome all day long, mainly because I think it's fun and it's makes everyone cringe, right? No. Irritable bowel syndrome is an interesting one because I always get lots of cringe responses in there when I talk about personal bowel experiences. But I don't get a lot of time when I can talk to hundreds of people about my personal bowel experiences. I just feel like this is the best time to really just let it all out there and just let it go, right? Just relax and just let it flow. Maybe not the best use of words, but I mean, this is how it goes. Irritable bowel syndrome is really classic in one thing that you can use to identify it, especially as a nurse, and that is alternating bouts of diarrhea and constipation. And the big thing is they usually have irritating foods. There's no way to diagnose irritable bowel syndrome except to rule out everything else. So rule out that you don't have ulcerative colitis, you don't have Crohn's disease, because those are things we can diagnose. But irritable bowel syndrome, what are some really irritating foods that could flare up irritable bowel syndrome. So what are some things you could feed me, most likely, that's probably going to flare up irritable bowel syndrome? Oh, all of these look delicious, and anyone here in the office who knows me knows that I can't eat any of these, and they're the first things out of my mouth. Heather says spicy foods. I would love to eat spicy foods, but I can't, because if I eat spicy foods, they march out of me like a fire, right? Exactly. Um, Fatty foods, not so much, but sometimes some people are specific to that. But the big one, and I see here, the next one is most definitely dairy products. Kalendi says dairy products. Dairy products, yes, there's lactose intolerance. That's its own thing. But what we see with irritable bowel syndrome is it actually really is usually a flare-up of irritable bowel syndrome. Why? Because when we consume dairy products, what happens when you have dairy? You know, you've got a carton of milk and you let it sit in the fridge for too long and it expired, then you opened it up. You realize that the carton's probably a little bit expanded and it's not so nice and it's curdled, right? What happens is if you eat that, it creates gas. And it's definitely a very gas-producing food, which creates expansion. And if we have expansion in there, that expansion then exacerbates peristalsis, and in IBS cases, extreme peristalsis, and a complete bowel evacuation, diarrhea, whatnot. So here are just our alternating wheel of regular diarrhea versus constipation, our corked-con toilet, just to kind of show you the differences. The next topic, something that is really important, and this is something, the best thing I can really offer you to really make sure as far as a value tool for today's webinar that you're really just going to sink into your mind and be like, wow, that Kendall guy, he's really kind of got some smart stuff up his sleeve. And this is just something that I've just taught for years that I just love to teach. I don't really love talking about poop in general. It just happens to just be a crappy conversation that I am talking about a lot. So my favorite topic, especially if you're a nursing student, is to talk about colostomies and ileostomies, right? But there are some really high yield points you have to know here. And one of those is really just understanding the idea that stool is formed more as we go further down the colon, right? I mean, that seems like a logical concept, but you know, I know that there's that table somewhere in your fundamentals book that you had to memorize as well that really talks about how it's, you know, it's mesenchyme and the duodenum, and then it gets to ileum is a little more formed, and it gets down to the large, you know, the cecum, and it's essentially like a chyme, watery, half blah blah blah, whatever. You don't really need to memorize all that per se for your exams long term, but you need to understand the process. So here we have. So what I need you to remember is. And as you need to try to remember everything we're about to talk about, whether we talk about appendicitis in a second or how the bowel is formed, I want you to just think about yourself. How do I remember what the colon is like on a body? Well, what is the answer to that question? And the answer to that question is a question mark. So I want you to draw a question mark right on. Sorry, I see lots of people writing jokes or commenting on my awkward statements in our question board. So I try to read them all, but I get a little distracted. There's squirrels all over this sound booth. So the question with about knowing the stools and everything is essentially a question mark. So if you draw a question mark, just look at this question mark I have right here in this sexy little thing right here. I see, love this question mark. It's great, right? Well, this actually outlines the bowel. So you can actually go in here and imagine the large intestine is drawn exactly like a question mark. So you're imagining a human body right in front of you in anatomical position in front of you. And you're going to draw a question mark right on that little bugger. In your mind, just draw, here it is. Here's the question mark. Here's how it outlines. And exactly what you can see here is immediately over here where the large intestine starts is the ascending colon. Going across transverse colon, that's pretty simple, right? Transverse is next. Descending is next. So do you need to, where is the stool the most formed? Well, it's most formed in the descending colon and the rectum. I mean, that's obvious, right? But now it's obvious. Maybe you were not able to memorize that right away. So it's less formed in the ascending, more formed in the transverse, almost fully formed in the descending, and fully formed in the rectum right here at the end. But what we do, we've thrown in this triangle here. And we're going to talk about the last sec for pancreatitis just at that little nugget at the end. So let's talk about colostomy versus ileostomy. So if I have an ileostomy, that's in the ileum. So we have this up here in the ileum. The ileum attaches on here. Here we've got our ileocecal junction right here, right about where this eye is going to be on this beautiful little colon character, just a little nugget. So that's about where the ileocecal junction is. And in that ileocecal junction, not only do we always remember that's where an intussusception happens in a child, but most importantly, we know that that's where the small bowel essentially attaches to the large bowel, right? So in here is the large bowel. And if I had an ileostomy, that's in the ileum, what do I know about ileostomy versus colostomy? What is the most important thing you need to know? What is it? One starts with I, one starts with C. Haha, you guys are genius. No. Nah, types of stool. Okay. Tell me a little more. Tell me more about these stools you speak of, these magical stools. Tell me more. That's right. So you guys, lots of you guys are typing in the answers here, and the answers are exactly right. So in ileostomy, you have to know that immediately you expect to be free-flowing, loose fluid from that. It's not formed yet at all. Because what is the function of the large intestine? Well, the large intestine essentially really as a whole, all it really does is it absorbs water. It really absorbs water. It absorbs some nutrients and chylomicrons, blah, blah, blah. Yes, but the main function is really to absorb water out of it to make it more of a formed stool. I just realized my nose is really sunburned. I think that's just sorry, there's lots of squirrels in here. I'm very distracted today. So it's very, very, sometimes the comments that come in the message board really throw me off. So I got to stop. I got to pay attention here. So ileostomy, yes, very loose stool because a colostomy it makes a more formed stool. So in a colostomy, I see formed stool. So what is an important thing here for ileostomy? What do I teach somebody with an ileostomy about diet? What do I teach them? They need to take what types of foods? Excuse me, a couple of you typed in, oh, my tooth. I'm gonna pull this out on the webinar one of these days. This tooth that I have, definitely need a root canal there. So the ileostomy, an ileostomy is a very loose stool. So we're okay with that. That's fine. We're not trying to firm up that stool. And the last thing we need to do is get that person to create more bulk in a loose stool, right? That's not the purpose. So an ileostomy gets a low fiber diet, very low fiber diet, and absolutely at all costs avoid things that are going to irritate, like popcorn, nuts, seeds, all those things you guys were talking about. Low fiber diet, very, very, very important. And a colostomy is likely more formed, and more formed is most likely, that's somebody that you may potentially increase. You can eat a regular diet or maybe a higher fiber diet to keep that stool from becoming very firm. And that all depends on where exactly the colostomy is located. Very often we have people with colon cancer, which we're going to talk about in just a second, that end up with colostomies as well. Now, the most important thing that I can teach you about a colostomy, and the most thing you have to memorize, we have a whole colostomy, ileostomy, care Picmonic as well, is to know you have to keep that diameter on a colostomy 1/8 of an inch. That diameter, what you have to cut around the colostomy pouch to put over top of that little stoma. I always use it. If you've never seen a stoma, then you really don't know. But once you see one, you're never going to forget me doing this with my finger and my little tongue. Because that's about what a stoma looks like. It's an outpouching of actual bowel coming out of the skin. It's sewn in. And you need to create your little outpouching 1/8 of an inch diameter around that. It's very, very important. Why? Because we want to decrease irritation, especially with an ileostomy, because it's liquid and it's very, very irritating. Because if that site becomes infected, can you just immediately just throw in a new ileostomy? No. I mean, that's definitely traumatic to the patient. It's not something you can do, and not really a very easy place to do. And lots of you guys typed in about nutrients and whatnot for ileostomies. Those things are definitely true. Kevin says ileostomies and colostomies are more red than my tongue, and that's probably the case as well. So quickly, let's talk about colon cancer. Not really a lot here for us to mention about colon cancer. The important thing is it's a really common cause of death. And we see a lot of diverting colostomies because of colon cancer. They have a resection, and then they end up getting chemo and treatment, and then they get a resection. But the most important thing about colon cancer, it's completely preventable. It is another one is it's just like breast cancer as well. If you find breast cancer early enough, you just remove it, and it's fine. So this is very important that anybody over the age of 50 gets a colonoscopy. There are specific guidelines about if you have a family member with colonoscopy, that you get a colonoscopy earlier than they were diagnosed with colon cancer. But the most important thing to memorize here is over age 50, you must receive a colonoscopy. Another thing you can do is a fecal occult blood test, which is just a nice poop smear on a little card to see if there's actual occult blood in the stool. Definitely not my favorite thing to do as a nurse is to, get a section of stool and get your little knife and cut out your little, stool sample section. Not really the favorite thing to do, but definitely one of the things that we have to do. Prevention of colon cancer. Seems like pretty easy stuff, but it's definitely one you're going to get as a high yield point. And it's eating a high fiber diet, a low fat diet, maintaining a healthy weight. And one thing I didn't put in here was having nice green leafy vegetables. It's definitely something that's going to decrease your risk of getting colon cancer for sure. Not really a lot I want to put in here with that as well, but just some other points. An important point that I do want to make with stool and blood in your stool or blood in your vomit is, what are we going to do? Well, as great nurses with our nursing thinking caps on, we want to know everything about it. I mean, oh, you had a bowel movement? Tell me everything, as Marley's favorite words that she likes to explain to me. Marley's our newest nurse that's joined us here at our Picmonic team. You'll be seeing her later on, but she has this really wonderful saying about anything that's going on, and I just decided to recreate it. But I just imagine Marley talking to her patients, and the patient comes in and they say, oh, I've got some, blood in my stool, and she says, tell me everything. Because as a nurse, you want to know everything about what's going on. You want to know characteristics. You want to know why, when, how, what it smell like, what it feel like, everything, right? What do we want to know about stool, blood in the stool? And that's just a couple simple things. The simple things here are, is it bright red or dark red? If it's bright red blood coming, if you had a stool and you had bright red blood, then you're going to think, yeah, probably maybe hemorrhoids or a bleed that's lower to that GI, to that area. So it's lower in the GI tract, right? It didn't have a lot of time to get digested. So it's lower in the GI tract. So if I vomit bright red blood, I vomit up bright red blood, then I'm going to have maybe a bleed that's a upper GI bleed, maybe in my stomach, a gastric ulcer, esophageal varices, maybe esophageal cancer, those kind of things. I'm vomiting up bright red blood. But if it's dark red blood, what happens with dark red blood? Well, if it's from my stool, if I'm having these dark red coffee ground stools, then that's digested blood. It's curdled blood, essentially. Your body has digested it, and it's turned out to this coffee ground, dark brown, black type substance. That's because it's probably if it's stooling dark red coffee ground type blood, it's probably digested, so it's an upper bleed that has worked its way all through. If you vomit up dark red, then that's most likely the thing you're going to be thinking about is an obstruction or a bleed or a vomiting up of digested would be more like a duodenal ulcer or some type where the blood has had time to digest as well. It's definitely not a good sign, and we see it a lot with elderly people because of these types of reasons. So one thing we want to talk about here really quick is bowel obstructions. Not really a whole lot here to talk about, but the big thing is the number one thing you're concerned post-surgically is what? There are different types of bowel obstructions. There's non-mechanical and mechanical. Yes, that's true. That's on your test. The number one thing you worry about post-surgical for any patient is, have you pooped yet, right? Have you pooped? That's all you care about. I love PACU nurses, but they are obsessed with whether you pooped or not, especially the outpatient ones. That's all they care about. Even as a medical student and a nurse speaking to patients in the PACU, hey, how you doing? Tell me everything. Have you pooped or not? Have you passed gas? Why? Because if you have gone under anesthesia, your bowels essentially are the last to wake up. So you end up with this neurogenic ileus, and we can't send patients home if that isn't important. Kevin says OB nurses worry about neurogenic ileus as well, and that is absolutely true. Anytime you're under any kind of anesthesia, that is the number one thing, because the bowels are kind of like this lazy, sleepy thing. If we need blood flow, if we're shocked, if you're a patient who's in shock, what's one of the places that your body deprives of blood flow first? Well, that is your bowels. It says, we don't need to digest, we need to run the heck out of here. So it shunts blood away from your bowels into, your cardiac, your peripheral vascular system. It's the same with anesthesia. Everything just kind of, the bowels really aren't that important. We're sleeping, so they're just going to ignore them for a while. So it takes some time for them to be reperfused and get kind of wake back up. And that's definitely something we always worry about, because we wouldn't send a patient back for that. Medication-wise, what medication would we think about? What medication would we think about if I said medication creating obstruction? This is so high yield, and you just gotta. Kalindy says narcotics, but which narcotics? What are we really worried about? And it looks like Kevin said morphine. Well, that's great, but what are we really worried about? Worried about opioids, and that's right. morphine is an opioid. All of those opioids cause bowel decreased motility of the bowel because they relax everything else and they just kind of, hey, bowels, don't worry about pooping, just keep it all in. That's kind of the way it works. Other causes include mechanical causes. The actual most common cause of a bowel obstruction is actually adhesions, and those are adhesions are just type, bowel which is scarred kind of together and created this constricted part, or it's usually because of previous surgeries or congenital problem. But adhesions are actually the most common cause of bowel obstruction in general. So just just a side note there for you. So we have different types of obstructions rather. We have a Picmonics for all of these as well. Oh, hold on, let me go back. I thought I had a hiccup, but then I thought maybe I needed a cough, but I don't know what's going on today. So let's quickly look at the next topic, which is hernias. These are our Picmonics on obstructions and types of obstructions, just everything I went over to help you memorize everything together. Now, types of hernias. This is something I just want to actually run you through the Picmonic to show you how we really tie, how you can remember everything together, which one goes where, or which one goes which. So this is a Picmonic. I'm just going to guide you through it as if I was teaching you a Picmonic like you'd learn in our Picmonic system. So types of hernias are really important to know the types of hernias, right? What hernias go where and when, and kind of how to keep them together. It's important to know the types of hernias as shown by our little hermit crab character throughout this entire Picmonic learning system. So there's a hiatal hernia, this little hernia hermit crab with a high hat. And that's hiatal is usually seen in gastroesophageal reflux disease, as you'll see here with our GERD girl for gastroesophageal reflux disease. And a hiatal hernia is essentially bowel that comes up through that sphincter where the stomach is. So the bowel or the stomach regurgitates up through above the diaphragm, and it causes this hiatal hernia. It causes a lot of GERD and is associated with GERD as well. Another one is inguinal. Inguinal is kind of we think about those kind of in the groin in general, but inguinal is, of course, in that inguinal space. Ladies, as most nurses are ladies, you always think about that V cut. That's inguinal in the groin. That's kind of we have our crab in the groin here. The big thing with inguinal hernias is they're most commonly in men, and that's one of the reasons why we screen most young boys for inguinal hernias, because it's a possible complication with lifting and whatnot. You strain and you cause this inguinal hernia. Another type of hernia is umbilical hernia. So we have our umbrella hermit crab here. So think about the umbilicus, and this is one I see all the time. I see it incidentally. These patients, you feel their belly and they got this little lump around their belly button, and it's a congenital defect just because the belly button fell off and it created a little loose spot. Because what's important to know is anytime that we've had surgery or there's a previous cut in any type of body tissue, it creates a loose area, because scar tissue is not as strong as regular tissue. How strong is it? Well, it's like 2/3, I think. 2/3 right away, I think, is the I can't remember the exact percentage. Femoral hernia, here's our femoral bone hernia. Femoral hernia are most common in women. You can see we got this woman with her femur and her little hemorrhoid hermit crab. And then incisional, and this is the one that you see very often. You see somebody who has an incision. So OB patients. Kevin talked about how he hated his OB clinicals. I'm right there with you. I hated OB. I still hate OB. But you end up with an incision, and those incisions are if you have a whatever the term is when they take the baby out and it's not, I can't even think of the word right off. Definitely not a very good blank to draw at this moment. But C-section, yeah, cesarean section, thanks, Heather. If you have a cesarean section, you have to have cesarean sections after that, mainly because it weakens the abdominal wall and you have an increased risk of uterine rupture, and that's really important because you've scarred it, and that's why incisional hernias are very common that we see. Anyways, any kind of incision could end up with an incisional hernia. And this is just kind of how we guide you through everything to keep track. Strangulated is something where you could have just an adhesion that obstructs things off and creates an obstructed hernia. One of those is like with pancreatitis, or appendicitis, which we're going to talk about right now. So here's appendicitis. Just a couple more things I just want to touch on, because I always end up running right against the time here for the hour that I try to always stay to. Appendicitis, we have this appendix pen here. Appendicitis is fun. The most thing you need to know about appendicitis, cholecystitis, which is next, is just a couple little things. It's so easy. And if I just jump back, and here I've got my signs and symptoms: rebound tenderness, right lower quadrant, fever, leukocytosis, risk for perforation, great. All those things are in our Picmonic. Let me see if I've got my, and here's my question mark again. So I went over all that. I love this little question mark, because this question mark lets me see exactly how I can always remember where the appendix is. This is something I struggle with. I am dyslexic, and I always mix things up that are common every single time. But I know how to draw a question mark. I don't know if it's just because I'm like to draw question marks. Maybe, I don't know. But I draw this question mark. And we drew this question mark here for you. So here's my question mark of my colon. And you notice this little nugget right here? See that little boop-de-doo right there, that little squiggly? That's the appendix, right? So if we have my ileocecal junction right here where this eye is, and there's my appendix, and I imagine that that's a body, and I drew this onto a human body. I'm imagining somebody standing right in front of me in anatomical position. I draw this question mark on them, right? Well, there's the appendix. So which side is the appendix on? Well, it's on the right lower quadrant. Right lower quadrant. Because if this patient right here with this appendix and this little poo-poo here was in anatomical position, this would be the left side and this would be the right side, right? It'd be opposite. So here I've drawn this wonderful question mark right on my imaginary patient, right in front of me, and right there it is. There's a little appendix poo-poo, and what do you know? Appendix, right lower quadrant, every single time. You're not going to miss it. It's so easy. You got it. You know how to draw a question mark, you have appendicitis. And that's almost the most common question you're going to get, right lower quadrant versus left lower quadrant, right? I mean, that's the number one thing students have so much trouble with. So it's definitely something you're going to struggle with, and this really just helps you get the answer. So appendicitis, we had a question of the day for appendicitis. A patient comes in, you believe it's appendicitis. What do you do first with appendicitis? Well, a really important point here with anybody with abdominal pain, just in general, it's really important that you do what before you palpate? Well, you always auscultate before you palpate someone's abdomen. Now, yes, I understand. Very often it's taught that the doctor palpates or deep palpates, and you only light palpate or you don't palpate at all, depending on what your school teaches you. But the important thing is you must auscultate before you palpate. And the other thing with appendicitis is it's rebound tenderness. And I can tell you, appendicitis patient always appears the same way. They have an increased white count, they come in with a fever, and they have this right lower quadrant pain. It's almost classic, so easy to catch. And you do what for it? Well, you do an ultrasound, and you find out that they have appendicitis, and you send them off to surgery. Whoop-de-doo. Good for them. We have a Picmonic for this as well, and I don't want to go too much into it. But the big thing here for a nurse is to know where it is, and it's definitely on that right lower quadrant. So the next one that goes right along with it is cholecystitis, so gallbladder problems. I mean, sorry, ladies, 95% of everyone ever listens to these webinars in nursing is a female. Well, what I got to tell you, you probably already know, is cholecystitis, right? So gallbladder issues. What are some signs and symptoms of gallbladder? Well, immediately you should be thinking about what types of foods. Ha, the 5F, Kevin says, is right. FFF. That's right. Everyone should be thinking about F's. Cholecystitis, F, 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 cholecystitis, F, 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 F this, F that, F that. That's right. It is F everything, cholecystitis. But the big thing, you always need to think about this characteristic fact, and that is cholecystitis, they usually have a pain after they eat. And what type of food is fatty food? Because what happens, think about the concept here. What does the gallbladder do? What does it really do? Yeah, you have fat in your diet. Your body senses the fact you have fat, so that cholecystokinin gets released, which then causes gallbladder contraction, and then that increases bile, which blah blah. No, that all is true. Those are not what you need to think about. You need to think about the big picture and the concept. And the concept here is you eat fatty food, and the gallbladder itself releases bile. Excuse me, I got the hiccups. Every week I think I get excited and I get these hiccups. But anyway, the gallbladder releases bile, and that bile comes down and helps break down these fat emulsions into smaller particles, amino acids, and break everything down so they can be absorbed by the intestinal tract. It absorbs fats. So if I eat a fatty food, after I eat it, I'm going to have this severe pain. Now, where's the pain? Well, let's think about where our body is. We have the liver on this right side. On top of the liver, we have a gallbladder. Underneath the liver, we have the gallbladder. So there's a right upper quadrant pain. And most importantly, it's after eating. Clay color stools, because we could have cholecystitis or cholelithiasis. Lithiasis means stone. Lith means stone. We could have this stone, which could obstruct the bile duct and cause no bile to come down at all, and that causes clay-colored stools, because we know that the bile actually colors our stool this beautiful brown greenish pigment, right? The gallbladder essentially just stores bile and concentrates bile from the liver. It just concentrates all this bile, it just stores it all, and then when you eat a fatty meal, the gallbladder goes, okay, here's a little squeeze of bile for you, and it squeezes a little bit of bile out. But if there's a stone or inflammation, it tries to contract and creates this extreme pain if you eat this fatty meal that it needs to help digest. And who's at risk? This is my favorite, all the F's. Female patients. We have an entire Picmonic for this. Female, fat, fair, light-skinned, fertile, pregnant, and usually at around their age 40. And when we talk about body shape, we talk about that pear-shaped. You can have that pear-shaped, you have apple-shaped. And that's probably something you also talked about in your nursing school. And the patients that are more likely the apple-shaped, the different types you can know with cholecystitis as well. So there's another important point, just kind of a high-yield little point there. I'm not going to talk too much about cirrhosis today, because this is definitely something we could go into really high in depth on, and types of cirrhosis and hepatitis, which we're not going to touch on today. But definitely cirrhosis in general, liver failure. So liver has lots of functions, but the most important thing with liver cirrhosis, what's the most common cause of liver cirrhosis? Hepatitis, yes. Alcoholism is what everybody always picks, but actually things like hepatitis, as far as the world, usually is more common, but alcoholism is definitely very common for sure. And it causes, chronic alcoholism over time causes cirrhosis, and cirrhosis is essentially this, the liver enlarges, and then it becomes cirrhotic and it breaks down and becomes very fibrous and can't repair itself. The liver is a great organism because it can repair itself. I mean, you can beat that thing up all day long, but you can only beat it up so much until it finally just starts to give up and can't repair itself. That's why we get, that's why you're able to detox so much. But it's essentially just a big giant detoxing engine. And one of the things it does is we see with cirrhosis, if it backs up and fluid backs up, I just want to back down here to the bottom, we see esophageal varices and hepatosplenomegaly. But why is because without going too much in detail with the anatomical structure, fluid backs up in the liver. It can't go through the liver and past it, so you end up with this portal vein hypertension. And that causes those telangiectasias. I can't ever say that word. Telangiectasias. It's not a word I've ever been able to pronounce, and anytime we have a Picmonic with it, I just ask somebody else to do it. But spider angiomas basically is another good word for it. But it's these little tiny blood vessels because of increased pressure as well in the stomach, the caput medusae that we see in the stomach because of this increased pressure, because the pressure can't go through the liver, because it's become this hard mass. Because the liver isn't working, liver is very responsible for breaking down urea, right, and turning urea into a product and ammonia, metabolizing ammonia so we can get rid of it. So we end up with this hepatic encephalopathy. And the important thing to memorize is, yes, we have Picmonics for all these to help you memorize that the fact with estrogen causes this pulmonary erythema and spider angiomas and gynecomastia. Those are all important because of breaking down estrogen. Let me just mention it or explain it since I said it. The liver, one of the things liver does is break down estrogen. Estrogen, or estriol, types of estrogen, is actually made by fat cells, and the liver actually breaks it down and gets rid of it. But if your liver isn't working, bye-bye liver, no more. You like the alcohol, enjoy the liquor. Well, you're going to end up with these man boobs, right? Because you have too much estrogen because your liver can't break it down. And you end up with this pulmonary erythema, this redness of the hands. You end up with spider angiomas. And a lot of this is because of this increased estrogen in your body that your liver cannot break down and get rid of. And that's why you end up with gynecomastia and liver failure. But you also end up with hyperammonemia, so you can't metabolize ammonia and get rid of this toxic ammonia. Nobody wants ammonia. But just an important point that's here is, how do we get rid of a high ammonia level? This is just really, really high yield that we need to know. Kevin says his instructor says to think of esophageal varices as hemorrhoids in the esophagus, and that's very true. So the esophagus veins and the glands around your rectum, your anus, are actually attached to this portal venous system. So if you increase the pressure in there, you end up with diverticulosis, right? This osis, this outpouching, which is hemorrhoids and essentially varices in your esophagus. And when you increase the pressure in those, sometimes they pop a little bit and then they just bleed. And that's why we have to ban them either in your rectum or in your esophagus if you have this liver cirrhosis. Liver failure is not a fun thing. Cirrhosis is not a fun time. So anyway, back to ammonia. What do we know about ammonia? Well, ammonia, the big thing, ammonia is actually made in the GI tract. It's made mostly in the large intestine with breaking down these beautiful green leafy vegetables. Especially, it creates ammonia. And we break this down, we create ammonia, and our body usually absorbs it, metabolizes, and gets rid of it. Well, sometimes it doesn't work. So we have to give these resins that bind to it and excrete it. So I either need to give you diarrhea, or I have to give you an enema to bind and then excrete it. And the big thing we see is lactulose. That's definitely the one you're going to see. And since lactulose is the trade name, I'm actually not sure. This is an important point I had a student write in. Is the NCLEX actually show polystyrene sodium, or do they show lactulose? And I don't really know. I'm going to look that up. It's definitely on my list of things that we need to know. But lots of you guys said lactulose, and that's important. So you can take lactulose by mouth. You're going to give them diarrhea. It's usually a liquid. Take 15 mLs of lactulose 4 times a day, and it's just going to bind to that ammonia, binds it. Your body can absorb it and it makes you poop it out. It gives you awful diarrhea. Or I can give you a lactulose enema, whatnot as well. But that's about the only fixes for it. I could give you antibiotics, but those antibiotics essentially, what do antibiotics do? They give you diarrhea. So I could give you Primaxine as an antibiotic, but it's really just giving you diarrhea and binding to it and excreting it out, because bacteria are actually in your gut what create the ammonia, the bacteria breaking down everything. So I know I'm over time. I don't want to go too much over today, but just really quick GI pharmacology, just really fast. If we have GI, just there are 4 big drugs, classes of drugs. H2 receptor blockers. We have acid, right? GI acid. Acid is something you have to maintain. So we have GERD. You produce too much acid. We can decrease the acid. We could decrease the acid with an H2 receptor blocker, which is histamine 2 receptor blocker, which decreases acid production. Or we could give you a proton pump inhibitor, which is a PPI, which decreases acid production as well. We have a pharmacology lecture next week, which I recommend you come to if you haven't seen our pharmacology endings one. But this is one right here. Tidine, you're going to so easily be able to remember tidine as the ending for H2 receptor blockers. Tidine, ranitidine, cimetidine. Because we're going to show a ranitidine and a cimetidine inside Picmonics. So you know these teddies are H2 receptor blockers. PPIs, proton pump inhibitors, always end in the ending prazole, P-R-A-Z-O-L-E. And I always get some student always says, well, what about azole? I mean, those are antifungals, right? And the answer is yes. But prazole with a P-R-A-Z-O-L-E are always proton pump inhibitors. How do I remember? Well, P, proton pump inhibitor, prazole, P. I remember that, proton pump inhibitor. Omeprazole, pantoprazole. It's not as important. Lots of students write in, do I need to remember pantoprazole was only given IV and omeprazole was only given by mouth? Not really so much. You can give one by, a particular route. Those aren't the things you're going to get tested on, especially when it comes to NCLEX time. It's just the fact that you can identify it. 2 other drugs that are really important, just some important points. Sucralfate, or trade name Carafate, which is not important. You don't need to know trade names, but sucralfate is an interesting one because it coats actual ulcers. So if I have an ulcer in my stomach, this gastric ulcer, sucralfate, I take this sucralfate, it goes in, and it's actually activated by the acid. You got too much acid down there making ulcers? Great. Take sucralfate, and it's going to create this protective layer over top of the ulcer, and then it's going to keep it from becoming painful. The important point with sucralfate is, of course, well, it requires that acidic medium to become activated, so you need to take it 1 hour before you would ever eat so that you can have this acidic stomach. You need to take it on an empty stomach. Crazy people, why can't you understand this? Sometimes I think patients just need to understand everything. But, of course, I don't yell at my patients, but sometimes I wish I could. Zofran or ondansetron. Zofran is a really popular antiemetic type medication, definitely one we use for anti-nausea. We also use phenergan or promethazine as well as an anti-nausea drug, but the big one of choice is ondansetron or Zofran of giving it. The big thing with all these anti-nausea meds is they usually work before the patient actually starts vomiting, and that's just a side note to have. Once they start vomiting, I mean, they're already vomiting, so you need to overcome some more mechanisms as well in addition. Just a side note here, Picmonic, all of these medications, we just mentioned 4, but we have a whole webinar next week I recommend you join. But we cover over 150 different medications just for pharmacology alone. So lots of different things in our entire product to memorize all of those drugs. And there's one thing I guarantee you will get lots of is drugs, and you must just memorize a bunch of crazy facts. This is what we're really good at for sure. So I just want to just put everything together, just a quick recap. A lot of everything I just said, whoops. But the thing is, remember what's different for each one. So remember what's different between peptic ulcer disease, a gastric ulcer versus a duodenal or duodenal ulcer. Know what's different. Know what's different between Crohn's disease and ulcerative colitis. Know what's different between ileostomy and colostomy. Know the big picture differences of them, the fundamental concept. And if you know the concept of everything, well, then you should be able to reason through with your nursing thinking cap how you need to treat it. And it's so easy once you really think through and understand the concepts. I see so many students who struggle with that just basic concept, putting it all together. And it's really just understanding it from the beginning. Maybe you didn't have a great understanding, I don't know, but we have all of these topics that we mentioned today in our Picmonic system, so you can go through and read through all of them, read the definitions, and get all of the information that you have to keep things straight. So what we have a promo code for you today for Picmonic. If you're not a subscriber right now, you can sign up for Picmonic system, and we'll give you a 20% off discount code to our fixed nursing subscriptions. And our promo code, I'm so excited for this one, is POO20, P-O-O-20. I love that promo code. Share it with your friends. It's a good one. It's definitely something that should go viral in the next 15 minutes. If you have any questions right now, now's a good time to type them in the question box so we can quickly answer some of your questions and get to those for you so that we can go over them and see in case I missed something or you didn't understand quite something very well. So if you have any questions, definitely type those in now. But if you're not a Picmonic subscriber, everything we went over today, aside from the big concept pictures, are inside our Picmonic learning system. We have over tons of different Picmonics on all of these different disorders, which go into great detail explaining all of the nitty-gritty facts that you really need to know. And all of those characters are associated, so it makes it so easy to remember peptic ulcers versus duodenal or duodenal ulcers. So easy to keep them straight. Definitely something you need to know for sure. So I'm just going to, so also just really quick before I answer questions, we have this promo code. It's off our fixed subscriptions. Someone always ends up asking how we do our subscriptions, and the big thing is we have a annual subscription for $99.99 that gives you access to all 750 Picmonics. We have an NCLEX study guide you can follow along, and the big thing, we have a mobile apps that you can download and use Picmonic on the go. To always keep on top of everything. And we have pathways, so whether you're studying for NCLEX right now or you're in a particular course, maybe you're taking pharmacology, we have them all organized out for you, so you can just go right in and follow along and make sure you're learning things well. So let's see what we have for questions today. So we just have a couple, so that's good. Diane asks, in Crohn's, why are they anemic if they're non-bloody stools? So this is an interesting point, and that we mentioned well early on. I just want to, maybe you joined in late. So anytime, it's just a concept that you really have to understand, or just grasp, not that you don't understand it now, but anybody that has a diarrhea, if you're having 5 stools per day, I mean, I have 2 stools per week, maybe 3, because I have IBS, alternating diarrhea and constipation. But if I had 5 to 6 stools per day and I had Crohn's disease, I mean, I'm moving everything I eat, I'm moving it out fast. I mean, it's in and it's out. Ulcerative colitis, even worse. The fact that it's bloody doesn't matter for the anemia. The fact that it's bloody, the fact that it causes anemia is what you have to think of. Anytime I'm increasing the motility and I'm saying I'm going to eat this giant cheeseburger and it's going to shoot out the other end very fast, is the fact that you're not able to absorb any nutrients. So any patient who has a resected bowel or a shortened bowel, or any patient who has a lot of diarrhea, is not able to absorb nutrients out of all of that sustenance that they're consuming and then of course excreting. So any patient who has a constant diarrhea is at a risk of a decreased absorption. Now, specifically with Crohn's disease specifically targets most preferentially the terminal ileum, and at the terminal ileum is where folate and B12 are absorbed. And without folate and B12, you can't create red blood cells, and you immediately become anemic as an early on sign and symptom. Ulcerative colitis blood loss usually doesn't cause enough blood loss to make you anemic per se. Yes, the diarrhea alone causes it, but it's definitely something you see anemia early on in the early stages of Crohn's disease before you would see it in an early stage, a very early stage of ulcerative colitis. But that definitely doesn't mean it doesn't happen, of course. So Jeannie asks, are the Picmonics just random, or when you subscribe, or are they by disease process? So the great thing about this, anybody can create a trial account for free if you're not a subscriber, but you can go in and we organize all of the Picmonics in multiple different ways. You can either follow along with a body system. Maybe we're doing GI. You can follow along by body system. We've organized them also, all of the Picmonics, as well by course. So maybe you're studying fundamentals. Maybe you're studying pharmacology. Maybe you're studying med-surg. You can follow along with med-surg by med-surg and topic areas. Or we also have organized them by book, so you can follow along with the most popular books that we have indexed, and we are indexing more books every day. So you can follow along with your book and see which Picmonics are rated by chapter, by page as well. So there are 750 of them available, and definitely cover everything you need to know in nursing school for sure. Definitely help you give you an up on your grade. So Victoria asks about a renal diet. Does it consist of a low potassium and low phosphorus diet along with a low protein diet? Here's kind of the way you need to think about a renal diet. A renal diet really just, it's just awful. It's just not fun. It's nothing, a renal diet is the worst one. The definite thing is you need to avoid things that break down. The big thing is definitely reducing the amount of potassium for sure, because potassium is that electrolyte that builds up the fastest, right? So it's definitely potassium and phosphorus, because phosphorus builds up as well, but it's most definitely just avoiding it's a lot of bland foods and a lot of things that don't create a lot of byproducts. I don't know if that's the best answer to give, but it limits the buildup of waste products. So it's low salt, low potassium, low phosphorus, and other pretty much all the electrolytes. But it's definitely not the best diet to be on. Renal diet is, if you think about why are you on a renal diet? It's because you can't excrete things. So you don't want to have a high protein diet because you're going to create urea, which has to be excreted. You don't want to have a lot of potassium because you need to excrete potassium. So you limit the potassium, you limit the phosphorus. And you limit all the electrolytes as well. But the big thing are fluid restriction, potassium, sodium, phosphorus. Those are the biggest ones for sure. Jen asks, are these all available with instruction? I don't really quite know what your question means, but if you wanted to rephrase it, I will see if I can answer it. Lots of love me statements. No, I'm kidding. I always take anything free you have. Shower me with gifts. I love gifts. Any kind of gifts. Not gifts. Gifts, like as in presents. Okay, so I'm not seeing too many other questions. I got a couple that I think we addressed, and that's for sure. If you have any other questions, you can definitely reach out to us. Steve in the background here at Picmonic is giving me some crap because I always try to throw in showering Kendall with gifts as often as possible. Not GIF, G-I-F, but presents, gifts, like things worth money for sure. Because I always mention that I get 35 cents every time I show this Picmonic cup. which is almost empty today. But we appreciate you coming. If you have any other questions, you can reach out to us at Picmonic, or excuse me, feedback@picmonic.com. I think I have that in here, so I can show you. Feedback@picmonic.com. You have a question, you're interested in something else that you have, you need help with. If you have trouble using setting up our system to learn, you can always reach out to us. Click help, email us right away. You're going to get myself or one of our other amazing team members here at Picmonic. And next week we are having a pharmacology webinar that you can join in. It's on the 20th. You can see it on picmonic.com/webinars. Oh, one question that I was so happy to answer. Heather asks, when will Android app be ready? And the answer is tomorrow. But if you would like to use the Android app today, you can email us at feedback@picmonic.com, and Steve will set you up with it today. But it is coming out in the next couple of days. You are welcome, Heather. It's definitely something that a lot of people ask for, but it is out. We have our beta version that we are internally testing. We are releasing in the next couple of days our entire Android app. We're so excited about it. But lots of nursing students definitely requested that for sure. But if you have any other questions, reach out to us. We're students for students. It's definitely something that we always say, and it's definitely true. Reach out to us at feedback@picmonic.com if you have any questions, concerns, gripes. We're here for you. As always, good luck studying, and have a good night.